Hello, this is Hallie again. I'm going to do a brief lecture on your assessment of the ears. We won't have the otoscopes available to use with the assessment of the ears, so we're just trying to adapt it to the best we can. There is some content in here that you will see on the exam that has to do with the the otoscopic exam. So I will kind of make sure to kind of clue you in on that to pay attention to that. We tend to use more otoscopes in a clinical setting than we would of the ophthalmoscopes, just because of foreign bodies, impacted cerumen, and especially in pediatrics or in our younger population, they tend to get a lot of ear infections. So we tend to have a little bit more use of that tool versus the ophthalmoscope. Okay. All right. The ear, just review your structures. The external ear and the middle ear are separated by that tympanic membrane. So everything from that tympanic membrane out is going to be considered middle ear, and then on further out is going to be your external ear. The external ear is going to be your auricle, or the pinea is the technical term for that, and the external auditory canal, just that part that you can see. Cerumen, or earwax, that's made by sweat glands, and cerumen's a good thing, but if we have too much of it, sometimes it can, we can have too much of it to a good thing. It can cause some problems. It does help us protect from foreign bodies, but if you get too much in there, sometimes it can become impacted and it can cause problems with hearing. The tympanic membrane, when you visualize it, if you're able to see it, and if you have that otoscope, it should be translucent. You should be able to kind of shiny, pearly gray, and translucent. Those are typically the structures that we look at with an ear assessment. The middle ear and inner ear, those aren't things we would be able to assess with the tools that we have. So here is just a review of the structures. Here's the auricle, or the pinea of the ear. This is your external auditory canal, and that's that tympanic membrane. Again, it should be a nice pearly gray. So this is kind of the area of the ear that we're going to focus on. Conductive hearing, again, we usually have a transmission of sound that goes through that external canal and goes through the middle ear. When you have conductive hearing loss, that's usually something that's blocking that transmission of those sound waves. And that might be because of earwax, or if they have an infection, acute otitis media. Acute means new onset, or sudden, or otitis is ear, and media is going to be like an ear infection, middle ear infection, or an inner ear infection. Foreign bodies, perforated eardrum. Again, sometimes that eardrum may be perforated if there's a lot of history of infections, or if there's an infection in there and there gets a lot of pressure in there. And otosclerosis, sometimes that eardrum, if they've had a history of a lot of infections, that eardrum, that tympanic membrane rather, can get really kind of hard and get a lot of scar tissue on it, and that can cause problems with hearing loss. The sensorineural hearing is transmission sounds of the inner ear. That's something going on inside of the inner ear, like an injury, a neurological injury, or nerve damage. Okay, so that's the difference between conductive hearing loss and sensorineural hearing. Please feel free to review this slide. I'm not going to read it ad nauseum, but I do want you to pay attention to the older adult considerations. This one here and this one here. Please kind of review those. I think one of those questions are on your study guide for your exam. All right, your external ear assessment. Again, you're just going to inspect the external ear, how the position of the pinea, or the auricle, is on the head. It should not tilt back or any further back than 10 degrees, and I do give an example of that in my little video that I did for you, my demonstration. Look at the auricle, check the size, the color should be uniform with the rest of the body. Are there any deformities on the auricle or any type of lesions? Sometimes you can see keloids or different skin tags, or sometimes they have some other issues, which I'll talk about in a few minutes. Look at the lateral and medial surface. Make sure to look all around the ear and any of the surrounding tissue around the ear. The position, again, and the tilt, again, we do have some neurological problems and some chromosomal problems that will cause the ears to tilt back a little bit different, or the ears will be a little bit lower set on the head. That's why we kind of take those measurements. Again, so here's your normal ear attachment. If you have the outer canthus of the eye, the ear should align with that outer canthus of the eye, and the degree of the ear tilting back should be no more than about 10 degrees. If you have a deviated alignment, maybe the ears are a little further set back, you have a greater than 10 degrees, or if the low set ear attachments, if you look here, the canthus of the eye, it's lower than that outer canthus of the eye, the ear, the top of the auricles. That's a low set ear attachment. Again, that may be because you see that things like Down syndrome, fetal alcohol syndrome, and some other neurological abnormalities. The auricle color, again, should be about the same as the face, should be all uniform. If you have any type of blueness of the ears, the term for that is called cyanosis. Usually if someone's having a problems with oxygenation or perfusion, they're not getting good blood supply, usually one of the first few places you're going to see it are going to be in the ears and also in the extremities. So we do kind of like look at those ears. If the ears are excessively pale or excessively red, it may be because of a vasomotor instability, or maybe something's going on with their vessels or even their pressure. Extreme pallor may be because of frostbite. Well, it's kind of concerned because they do kind of aren't protected at times. They may not be protected, and if they do have frostbite, it gets very, very white in color initially. We like to look at the ear lobes. We got to see if they're attached or unattached, and if there are any gravity creases, and I have another photo of that here shortly. Or there's something called a cauliflower ear, and that's generally that happens from people who what I see are like fighters, boxers, anybody who has taken a lot of hits to the ear. They tend to get some scar tissue built up around the ear, and they call that cauliflower ear. There's tophi, and also sebaceous cysts can occur on ears, and that's just a cyst in the sebaceous glands of the around the tissue of the ear. Here is a photo of an attached earlobe versus an unattached. So you can see this lobe is attached, this lobe is unattached, and usually that's a genetic thing. It's a marker that's you usually get that trait that's passed down from one of your parents. A Darwin's turbuncle is this little guy right here. It's just a little abnormal growth of skin. The cauliflower ear is what this is. Cauliflower ear, again, that's usually from boxers or MMA fighters. I see them frequently. It's usually from getting a lot of injuries into that area, and it kind of like builds up with scar tissue and swelling, and they really just kind of get this deformity, and that doesn't go away. And then this gravity crease right here, sometimes they do believe that might be related to cholesterol as well. This little crease, they get these little folds in their earlobes. All right, so now that we've inspected, we're going to palpate. So you're going to palpate the auricle and mastoid area for any type of tenderness. The ear should be nice and firm, but very mobile. That cartilage should be easily mobile without any discomfort. And it should recoil or kind of like snap back quickly if you kind of move it. Gentle pulling should not cause any pain with that earlobe. The ophthalmoscope, again, here's going to be your handle, and this is the area where the light is emitted, and this is what they call the speculum of the otoscope. Okay, this part is the part that goes into the ear. On an otoscopic exam, this is where we like to look at the middle of the ear or the external auditory canal, as well as that tympanic membrane. We try to use that largest speculum that's comfortable. We can take those off and on, and they are single use. You throw them away when you're done. It's helpful if you have the patient tilt their head to their opposite shoulder. For example, this gentleman kind of is tilting his head over to his right shoulder. That way it kind of puts that that canal is kind of like opened up where you can visualize it a little easier. This is very important, again, because we frequently have so many pediatric patients that have a lot of frequent ear infections. If you have a toddler or a child that's or like, let me reverse that. If you have anybody that's older than 3 years, you're going to pull up and back. You have to pull the ear lobe or the pinna, not the earlobe, the pinna or the auricle, pull it up and back, and it kind of helps align that ear canal or that external canal so you can visualize that tympanic membrane. If they are younger than 3 years, you're going to pull down and back. And the way I always remembered that was that if you're older, you can go to a pub, and that's pull up and back, P-U-B. Older, go to a pub. So that's how I always kind of made that distinguishing that the older people, you pull it up and back. For its younger, you pull down and back. And there is client younger than 3 years, pull down and back. And again, if you have a child, if you're working into a clinic or an urgent care emergency department or pediatric clinic, we always do that otoscopic exam last because they really do not like it. And it's very uncomfortable for them. They don't like typically someone coming after their ears. So we try to do that last. So that way we can listen to them, listen to their bellies, and listen to their hearts and their lungs and all those other things that we need to do. And then by the time we get to their ears, because we know they're going to scream when that happens. So that's why we kind of like reserve that for the last, because it's kind of the scariest thing for them. Excuse me. This is just a general guide on how to use an otoscope. Again, you're not going to be responsible for using this instrument, particularly this summer. But this fall, if you do want to kind of go over it and use it or see how to use it or try to use it, feel free to contact myself or Dr. Nichols. And when we get our new devices in and it's safe to come to the college, I'm more than happy to make an appointment with you so you can just kind of handle the equipment so you can kind of become used to it. And we'd be more than happy to do that. Again, you're going to be responsible for a few of the items on how to use this particular equipment, but we won't be physically handling it this summer since we are online. All right. When you use your otoscope, again, we like to look at that auditory canal from the meatus to the tympanic membrane. So you're just going to kind of look at that external canal. We're looking for any type of discharge, scaling, redness, lesions, any type of foreign bodies that might be in there. And again, that cerumen or that earwax. Normal should be about some minimal cerumen, and it has a variety of colors. You can find it like almost a bright yellow to almost dark brown and black in color, just depending on the person. Nothing's wrong, but it should be a minimal amount. Sometimes, as they get older, they tend to make a little bit more earwax. The canal itself, that auditory canal, should be nice and pink. You should see little hairs or little cilia inside the ear. That helps keep foreign bodies and debris out of the ears. There shouldn't be no lesions, no discharge. You shouldn't see any type of foreign bodies, and there should not be any type of foul odors or any type of odors present coming from the ear. And if you are able to visualize the tympanic membrane, if you ever want to use that otoscope, this is what you'd kind of see. It'd kind of have a gray, translucent, pearly gray covering over it. But these are the little underlying structures of the ear. Again, it should be a translucent pearly gray, but sometimes if you look really good and if you have a good visual, you can see the umbo visual. And we talk about the cone of light. Remember, there's some light that's being projected through that speculum of the otoscope, and that light should reflect off of the off of the tympanic membrane. That right ear, because of the pressure behind the ear, that right ear, that light should be reflected right here about 5 o'clock. If it's your left ear, it's going to be reflected about 7 o'clock. The way I always kind of remember that, it's always kind of like towards the nose. That light should be towards the front of the face, where that cone of light is. And that just basically tells us how much pressure is in the ear. If there's too much pressure or not enough pressure, or if something else is going on, maybe because of infection or something else going on in there, again, because of that's going to happen behind that tympanic membrane, it's going to make the reflection at a different area. So that's why it should be at 5 o'clock for the right and 7 o'clock for the left. And if you look there, this ear here, you see sort of the structures under the ear. It would be more of a pearly gray. But what I kind of want to, and there's the umbo, what I want to focus on right here is the cone of light. And if this was the clock face, this would roughly be at 5 o'clock. So there we are. So that would be our which ear? Okay. Yeah, that's your right ear. Okay, let me see here. Here are some abnormalities of the tympanic membrane. This is basically just kind of an acute otitis media, or just a general ear infection of that middle ear. This is some blood behind the tympanic membrane. It just kind of accumulated back there. This is the tympanic membrane where it's perforated. They got a hole in the eardrum. That's what that is. That's a perforated tympanic membrane. This shows some serous otitis media. It's got some bulging. It's got a lot of fluid back there. There's some problems going on inside this, behind this eardrum, or behind this tympanic membrane. This one is probably have had a lot of ear infections, and you can see that there's been some scar tissue happening with this eardrum. This one, if you look, it almost is kind of hard to look at, but the eardrum or the tympanic membrane's kind of retracted, because they usually like negative pressure, because there's a problem with the fluid in the ear. All right, the whisper test, and I do give an example of this on my little demonstration video. It's just a general gross hearing exam for normal people, or for normal hearing rather. You're just going to stand behind your client, have them cover one ear, and you're going to whisper into the other ear. Just usually give them a general command. The Romberg is more of one of the neurological tests, and Dr. Nichols will go over that here in a few weeks. When we do that Romberg, just make sure you're prepared to support them, even though it really kind of tests their equilibrium, and as some people, if their equilibrium is off, they will sway side to side. So it's always very, very important to be prepared to support your client. You'll learn more about that in a few weeks. You won't necessarily need to do anything. That will be with the neuro assessment, not with this one. Other specialty tests for the ear, an odometer. That is a test that will do like specific decibels and frequency. That's one of those more advanced hearing exams or hearing tests. That's usually done by an audiologist, took me a second, or by a doctor that specializes in HEENT, head, eyes, ears, nose, and throat. Or the Werber, that's kind of tests for hearing loss with lateralization to the poor ear. There's the Rennie test. It tells them whether they have conductive hearing loss versus the sensorineural hearing loss. It kind of gives a differential between one versus the other. Proboscis, this is just kind of those lifespan variations. As they get a little bit older, and sometimes it's due to the constant exposure of lots of sounds, loud sounds over the years, but they tend to lose that loss of high-pitched sounds. They can't hear those really high-pitched sounds first, and then it starts to gradually lose some of those lower-pitched sounds. Also, when they get older, the cilia, or those little hairs in the ear that help keep those foreign body out, they become more rigid, and it allows some of that earwax to come accumulate and build. And that's also when we see a lot of the impacted cerumen, or have a lot of issues with the earwax in the ears. The earlobes tend to get a little bit elongate with some linear wrinkles. Again, they just lose their collagen and some of the elasticity. And the hair, remember, they kind of lose hair everywhere else except it starts to kind of grow out of their ears. They get lots of tufts of wire-like hair and roughly in the canal entrance, and it's more prominent in men than women. The tympanic membrane, it becomes a little bit more retracted and prominent with the landmarks on when you're able to assess that. And that is about the end for ear assessment. If you have any questions, please don't hesitate to let me know. Again, there's a lot of information in here that we won't go over. It's very basic what we're doing with our ear assessment. And on a normal head-to-toe assessment, you wouldn't be using an otoscope anyway, only if it was like a focus assessment, and that's generally happens more with your pediatric clients or your more elderly clients if they're having some issues with impacted cerumen or something like that. So let me know if you have any questions. Thanks.